Thank you so much. I'm going to be giving an update on data from our lung cancer screening program in Phoenix, Arizona. We use the I-ELCAP protocol, I-ELCAP reporting, and we collaborate with I-ELCAP since 2012. So in the VA system, in general, we know that the earlier we detect the lung cancer, the better chances for survival. The National Center for Lung Cancer Screening in the VA reported in 1st October that approximately 2.6 million patients in the VA system national have information about smoking. Of those, over 500,000 have been evaluated to see if they are candidates for lung cancer screening. Over 400,000 have been recruited into lung cancer screening. And today, October 1st, 250,000 still actively participating in the program, about a 61% retention rate. As you can see on the bar graphs underneath, the staging of the non-small cell lung cancer diagnosis in the VA has been, stage 1 has been increasing. And by 2024, it appears that at least half, if not a little bit more, of non-small cell lung cancer in the VA are stage 1. So things are improving. At the Phoenix VA, we do things a little bit different than other VA facilities. We use a process called multi-omics precision outreach. We don't wait for the primary care providers to push the patients toward our program. We develop a dashboard, a VA LCAP dashboard with risk factors from the medical record that include health information, but also imaging, prior imaging information. Based on that list of risk factors, even if we don't have referrals, we call patients or we send them a text. So they can self-enroll and schedule a telephone call with us, or we call them and do shared decision-making and enroll them in the program. The bar graph that you see to the right indicates our workload since 2020. The blue portion is the new patients per year. The green portion is the annual follow-ups. And the red portion of the graph is the short-term follow-ups. This past year, we had 6,000 encounters in the hospital. We expect by 2026 that will increase. And for comparison, the light blue ILN column that you see in 3 years there, those are the incidental lung nodules that have been reported that we are capturing. We are seeing more people in lung cancer screening than the incidental lung nodules clinic. We are the largest cohort in our network. These are the results for the lung nodules workflow and management. Of course, the definitions are tabulated based on size and consistency. And the definitions for positive or semi-positive are different for baseline versus annual CTs. What you see on the Sankey plot to the right is the net result, a visualization of the workflows. So for the baseline CTs, 3,047 at that time, about 22% of the baseline CTs were actionable. The definition of actionable is not lung biopsy. It just means we cannot wait until the next annual a year from now. We have to do something before to reevaluate the patients. Whereas for the annual CTs, only 11% of them are actionable, but in either category, we send less than 1% of patients for consideration for biopsy. We have done a number of biopsies. 70% of the patients we recommend get a biopsy, and 64% of those have lung cancer, and more than half of those are early stage lung cancer. Our detection rate is about 1%, and the efficiency of the protocol at Phoenix is 1.4 biopsies for every lung cancer diagnosed. So to the far left, that's the cohort as I can represent it to you. We serve about 120,000 veterans. Almost half of them, a little bit over half of them, have atherosclerotic cardiovascular disease diagnosis. About 23% of them have a diagnosis of COPD. About 25% of them are cigarette smokers. The yellow dot is largely magnified. So you see the lung cancers that we are trying to diagnose. And what we are showing you is how many people we have to screen to go and try to pick those lung cancers early. We have reproduced those findings in collaboration with the Department of Energy at Oak Ridge. And we look at a cohort of 5 million veterans for 5 years. The proportions are pretty much about the same. So our patients with lung cancer in the VA, the rate is not significantly different from the general population in the US, nor are the cell types of lung cancer in the VA. We're currently working to improve our dashboard by adding other health factors, other imaging factors, and also genetic information from the Million Veterans Program. In addition to managing lung nodules, as you have heard already today, there are a number of other additional findings. Some of them are actionable information, perhaps none more important than the coronary artery calcification score. What you see in the tabulation is the CAC scores for men and women in our cohort. They are significantly different from one another. And we, in our note for the medical record, we not only report on the lung nodules and recommendations, we report on the CAC score and specific recommendations, implications of that CAC score. In addition to that, we wanted to learn more about how to help our patients because we noticed in our I-ELCAP dashboard that I'm showing you here in the left, that since we have been enrolling patients at the Phoenix VA for lung cancer screening, 10% of them have died. We are seeing these people at least once a year, sometimes more, and obviously they are not dying of lung cancer. The majority of them are dying of cardiovascular disease. And what I'm highlighting for you there, you can barely see it, is one patient that we have been following for a couple of years, 78 years old, he has diabetes, but no hypertension, a total cholesterol of 318, a LDL cholesterol of 211 or 212, having incidents of cardiovascular disease events and no statin prescription. So that called our attention because if we go and try to use the pooled cohorts equation that was designed to look at the general population risk for having ASCVD events, the vast majority of the people we're screening for lung cancer are in the intermediate or very high risk for having ASCVD events before we enroll them in lung cancer screening. In fact, we're looking back 10 years from the day that they had their baseline lung cancer screening, and the rates of events exceeds what the PCE equation would have predicted for them. So far, what we have learned is that both the CAC scores and the PCE appear to underestimate the rate of events, of ASCVD events, in this patient population of chronic smokers that qualify for lung cancer screening. And on the bar graph to the bottom of the right, what you see is that for every 5-year group between age 55 and 75 that we are screening in Phoenix, we have an excess mortality compared to the general population in the US that is not because of lung cancer. It's mostly because of cardiovascular disease. So we look more into this issue of the cardiovascular disease risk and treatment. And what I'm showing you here is a list only of the Phoenix VA of many, many patients with high risk for cardiovascular events, very high LDL levels, but no prescription for statins. Our PCPs didn't know about it. The patients didn't know about it. We're slowly addressing this challenge, and we're in the process of looking at it across the whole national VA system. And finally, effective last week at the Phoenix VA, we were told we don't get any more resources, no more coordinators for our program. So we need to work with the resources that we have. Of the 29 lung cancers we have diagnosed, 27 have COPD. Only 2 do not have COPD. We reported back in 2003 a paper that showed the incidence lung cancers association with low lung function, and it makes sense, and it is time for us with limited resources to move the smokers with COPD ahead of the line. So we have begun calling and texting our smokers with COPD. If we receive consults from the PCPs for other people that meet the guidelines but don't necessarily have COPD, of course, we will screen them, but we are going to bump the smokers with COPD ahead of the line. And what we expect is the red line efficiency for accruing patients into the lung cancer screening program. So I'm speaking here for many, many people, including the I-ELCAP program here in Mount Sinai. And thank you for the invitation to share this information today. Thank you.